Thank you for the invitation, especially John Ward for the invitation to this prestigious symposium. And thank you everyone to staying up too late this afternoon. So as you heard from the Professor Chen's presentation this morning about Thailand is among the the highest incidence of hepatocellular carcinoma, and 70% of hepatocellular carcinoma are the result of Hep B and about 20% Hep C. So that's why we are focusing on the treatments of chronic hepatitis B and C. Here is the outline. So Thailand is the high middle income country, but we are the fastest growing aging community. So we go old before becoming rich. So now the population start dropping. So as for now, there are 47 million, and among this, about 20 million working in the system. About 11 million register as a taxpayer, but only 5 million have the income that eligible for paying tax. So then the rest of the people got to be covered by the government funding. So as for now, the universal coverage cover about 47 million people, and this implementation for universal coverage has been implemented 25 years ago. So everyone got to be covered, and when you go to the hospital, it's going to be free of charge. That is the way that the Thailand healthcare system. So what about hepatitis B and C? So we try to follow the WHO pathway. So follow the 10 actions to advance the public health approach. So with this collaboration, so we have the Ministry of Public Health. They keep changing faces every few years because they get promoted and they got new faces coming. And we have the Liver Society, we have Liver Foundation, and we have strong health technology assessment to assess in terms of cost effectiveness of every implementation to the healthcare system. So now, what about delivering the high quality evidence-based and people-centered services? So we did calculate for one-time testing for Hep B and Hep C, and it was cost-effective since about more than 10 years ago, but it's been delayed until implementation in 2023. And the treatment of Hep B was cost-saving. That was with the lamivudine and TDF. That was in 2013, and it's been listed as a standard of care for everyone. And treatment of Hep C was cost-effective with PEG and RIBA, and being reimbursed in the patient where the fibrosis more than F2 since 2014, and then switched to soft redispasia, and nowadays software with its cost saving. And the treatment shift from policy into implementation, and this treatment is free for every healthcare insurance, and both Hep B and Hep C are now prescribed by primary care physicians. In terms of prevention, Thailand has introduced the universal vaccination, the pilot program in 1989, and the nationwide implementation in 1992. TDF and HBV has been implemented for the pilot in 2016 and nationwide in 2018. And universal blood donor screening includes markers and NAT for every unit of blood components since 2002. So when we look at the shift of the surface antigen, this is the 10-year span from red, blue, and to black. You will see the shift of S positive among those who were born before the vaccination era. So and with this, the children below age of 5, mostly the incidence is just about 0.01, so very, very low in the people who born after vaccination era. So this is the timeline for our hepatitis B implementation. So that after the implementing the mother-to-child transmission, we introduced the nationwide screening for hepatitis B, and also TAF was eligible for the treatment at the National Health Care Benefit Package in 2023. And as for 2023, we started to have the next thing to do is a birth cohort screening for both Hep B and Hep C. And as for now, the people born before 1992, the incidence of S positive could be prevalence is about 2.1 to 2.3%, and those who born after it could be about 1%, 0.1%. And what about Hep C? So Hep C in the past, among the risk factors could be blood transfusion before screening. We have the blood donor screening, history of period, and also reuse of syringes and needles in the remote past by unqualified people in the village. But all of this had been solved, and period in Thailand is quite minimal. It's just a small group of people because methamphetamine going to be more prevalent in Thailand. So in up north, in the Golden Triangle and down south, going to be the people using drugs in less than 100,000 people. And with that, when we look at the shift of the prevalence of chronic Hep C, you can see again, so mostly going to be positive in people who born more than, usually the age more than 40. And this is also true for first-time blood donor. You can see both Hep B and Hep C. You can see the drops of the surface antigen. For Hep B is about 0.15 and Hep C 0.08 currently. So with that in mind, so we introduced the birth cohort screening for those who born before 1992, with all of this evidence. So that comes to about 35 million people. So in order to expand the treatment for hepatitis B, Professor Lim just talked about the treatment for hepatitis B regarding the HBV DNA, and also we would like to expand the treatment to at least more than 50% of S positive. So we follow WHO guidelines. But in some population, for example, in comorbidity, for example, diabetes, metabolic dysfunction, this accounts for 30% of Thai populations. And then we know that TAF can have some metabolic dysfunction, and with the result from the colleagues from Taiwan, 2 studies from the Taiwan, I'll show later on. So we skip this and use the EPI score or viral load as an indicator, and also the persistently abnormal ALT, because I think we can access to the viral load quite easily. And this is the reason why we do not add the TAF for the people with MASLD or diabetes, because the evidence by WHO was weak, and also with the recent study from the Taiwanese colleagues that the interplay, complex interplay between MASLD and the hepatitis B is quite still controversial, and the important issue going to be the viral hepatitis, whether B and C going to be dominate over the MASLD. So we think that may be more important than the MASLD. So we look at MASLD or diabetes with significant fibrosis or with significant viral load. And then we look at whether how many percentage of the with this implementation, how many percentage could be covered by the current indication. So this is going to be the population from my hospital together with Chulalongkorn Hospital, so more than 1,000 cases. About 26% got to have EPI score more than 5. So at least one-fourth of the patient can be eligible for the treatment without DNA. And then for the DNA, more than 58% going to be more than 2,000. So at least we can capture more than 50% of those who are S positive. So this is the final guideline. So in the primary care setting where access to viral load may be limited, so they can at least access to EPI score or people with histories of cirrhosis or hepatocellular carcinoma in the family. They can account for almost 30%. And then the presence of these comorbidity, except for the MASLD, where we need EPI score or viral load to be the indication of the treatment. For the treatment with the viral load, anyone with viral load greater than 2,000 could be eligible, this regardless of ALT. So because it's too complicated. So, and then I think the treatment is a prevention for HCC. So all of these things could be decision sharing between the patient. Usually, people in the rural area could be more acceptable for the treatment, but where the people in the city could be much more negotiation because they know that the treatment could be lifelong or longer period of time. So they need more negotiations. Then it depends. So then whenever they are ready, then they got to be given the treatment. This is the scheme where we did. So we have birth cohort screening. This could be done at the community level, the outreach from sub-district hospital with the healthcare volunteer, and this can be done with the point of care testing together with Hep C. And then if the test positive, they can be referred to district hospital, which is nearby within usually less than half an hour reach. And then if the APRIs or high-risk history, then they can be started with the TAF. For those with API less than 0.5 or negative history, we need viral load. But you see, where the universal coverage, the government cover just about $130 per people registered to the hospital. So for the hospital, the more they screen, the more they treat. That means they're going to be deducted by this overhead $130. So just only less than 20% of these S positive got to have DNA testing. So that with that's a problem. So we have negotiation with the government. So next year they provided funding for at least one-time DNA testing extra to the overhead payment. So this is going to be better in terms of access to DNA. And then we are talking about having a central procurement and supply for free without deduction from the overhead payment by buying the TAF for an extra reimbursement. And also the most important thing is how to promote adherence to these patients because it's going to be long-term treatment. In terms of mother-to-child prevention, we implemented nationwide screening for all pregnant women since 2016. Last year, we got about 500,000 pregnant women, and then about 5,000 S positive. However, just only 20% of S positive go for DNA testing or E antigen testing. Thanks to the new WHO guidelines, so we now, for those who cannot access to DNA testing, they can go ahead and start TAF or TDF treatment for these pregnant women without the knowledge of DNA or E antigen. Actually, E antigen is not useful because for these women aged more than 30, the E positive could be less than 10%. What about the Hep C service plan? Again, we cooperate Hep B and Hep C all together. So all people going to be screened for both Hep B and Hep C at the same time. So for those who Hep C positive, then we can have the RNA or antigen confirmation, and this could take maybe a week, but this kind of screening is linked to the national ID, so we can track the people and bring back the people to the track of the treatment. And with this, we can reduce in terms of the dropouts, because the genotype in Thailand about 50% genotype 3. In some cases, we need to add ribavirin as part of the treatment into the software. And both of RNA testing and the drug, this is extra reimbursement from the overhead payment by the government. So this is a special funding from the government. So actually, the hospital will get benefit from this kind of treatment, because they have different, they got about $10 more from reimbursement from the government. So they have some benefit by treating more patients. So what about the product regulation and procurement and supply? So the drug is now produced by the government pharmacy. So this is the drug that brought by Mylan and with the oversight of Gilead for TAF, TDF, Tequivir, and Software. So this can be unrestricted supply. So we just tell the government pharmacy how many cases we need this year, then they got to produce for us. For both drugs, this could be fully covered by the government. The point of care S antigen and also lab-based anti-HBV and S antigen, this also fully cover an extra budget from the overhead payment. And as I told you that DNA for RNA for Hep C is an extra, and next year DNA for Hep B is going to be an extra payment from the government. So with these collaborations, we have strong network of healthcare volunteers. This is a village healthcare volunteer. There are more than 1 million of healthcare volunteers. This is the way to connect between the village to the sub-district and district hospital and also provincial hospital. And this can remind them of getting the drug refilled, remind them of next visit and with using of this healthcare volunteer. And what about the implementation? As I told you that the program started in 2023, but the actual kickoff was in the mid of last year. Last year, we targeted for 1 million, but actually 2.8 million were screened. And this year, we target for 3 million, but the first 6 months, we achieved 2.7 million. Next year, we target for 4 million. So then every year, it should be 4 to 5 million. And with all of this, we think that we can achieve the target of 90% screening by 2030. What about the challenges for hepatitis B and C screening and treatment implementation? The first thing is the data. The data accountability remain weak because the linkage, because different healthcare schemes, I think they have different systems, they're not integrated, and national data system is still fragmented. Separate data from, as I told, from different schemes. And the awareness, this is very important, especially for hepatitis B. I think WHO should change or should emphasize that hepatitis B is not carrier. It is hepatitis B disease. It's not a carrier anymore. Because this is very important. It's not like HIV where people know that if they don't get treated, they are going to die. So this is very important. And for the care, we need to strengthen the service delivery, the healthcare load, and then also the quality of care, and to measure the outcome. So in summary, ladies and gentlemen, hepatitis B and C remain a major public health threat in Thailand. New WHO guideline and the ADAPT national guideline expand the treatment eligibility and access. prevention strategies and universal vaccination have reduced the incidence of both Hep B and, with this prevention, also Hep C. Affordable and effective treatment are available free of charge in Thailand. And the key challenges could be the data accountability, awareness, service delivery, and with this strengthened qualities of care, and the outcome measurement is essential. With that, thank you.